We will just wait a few minutes for people to come in, well, a few seconds actually, for people to come in from the waiting room. We'll just give it a few seconds more. People are crowding the door to get in to Susie's talk. Okay, well, good afternoon. I'm Professor Shane Dark and welcome to the weekly NDARC webinar, which, as you know, we broadcast live from the ballrooms of Mars. Now, before we begin, while we're widely dispersed, we acknowledge traditional owners of country throughout Australia, recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. Look, it's our speaker this week. It's a real pleasure to welcome Associate Professor Susie Nielsen back. She is, of course, we've known to very many in the drug and alcohol field from multiple venues. She's currently Deputy Director of the Monash Addiction Research Centre at Monash Uni. And indeed, she worked, the great pleasure of working with her at NDARC for many years until a couple of years ago. Now, Susie's background is in pharmacy. She's a trained pharmacist. Both her undergraduate degree is a Bachelor of Pharmacy, and her PhD was in pharmacy and pharmacology, which places her in an ideal place to discuss what we're going to speak of. Now, Susie's major current research focuses on understanding how to improve the identification and treatment of prescription opioid disorders with the aim of reducing harms associated with their use. Now, this forms part of a broader interest that she has in the implementation of prescription drug monitoring and the impact of policy level intervention to reduce harm with such drugs. Now, I'm absolutely certain that most viewers there will be aware that in the past decade or so, or slightly more, there's been an explosion, an international explosion in prescription opioid use, and it's become a major public health problem, particularly when we look at countries like the United States. Now, in this presentation, Susie provided an overview of the development of the Routine Opioid Outcome Monitoring tool. Now, this is an intervention aimed at the interface between the pharmacists and patients looking for problems related to opioid use. It was a very complex issue, but pharmacists have a crucial role in that space between the prescriber and the patient. Now, what she's going to do is she's going to share findings through a pilot implementation conducted with 23 pharmacies from New South Wales and Victoria. Now, we're delighted that we're going to also be joined question and answer session by Dr. Gabrielle Campbell, now of the University of the Sunshine Coast. Of course, Gab worked till last year at the National Drug and Alcohol Research Centre, and she's a recognised expert on chronic pain and opioid dependence. So we're going to have her for her perspective on this important talk. Now, you can log into questions on the Q&A function on Zoom, which I'll relay to our panelists at the conclusion. If you could restrict yourself if possible to 2, and we may not be able to ask all of them, but I would certainly do my best. So now, Susie, it's over to you.
Great, thank you for that introduction, Shane, and it's nice to be back presenting in an NDARC webinar. Let's see if I can get my slides to move. So I am excited to be presenting this work at the NDARC seminar series. This is work that I actually started during an NHMRC translating research into practice fellowship at NDARC within the drug policy monitoring program with Alison Ritter. And this really set me on a path which I wouldn't describe as a linear path, but a path where I developed a great curiosity and passion for implementation science. And it was also a good opportunity to bring together my passion for understanding and responding to prescription opioid problems to start to work on some solutions at that clinical interface. And it seems like a good opportunity to present the full body of work really for the first time to a public audience in its entirety at this webinar. So in terms of prescription opioid mortality, as Professor Dark already mentioned, we've seen large increases in opioid-related mortality. We have seen a larger proportion of those deaths involve prescription opioids, around 70%, but of course not to ignore the fact that heroin-related deaths have also been increasing. Amanda Roxburgh released a study last year that looked really closely at that prescription opioid mortality. And I think this really starts to unpack some of the nuances. And there isn't one clear group which requires one specific response. There's a range of different populations that are affected by mortality here and different layers of complexity. But overall, when we look at the range of deaths, we see that among prescription opioid deaths, things like chronic pain and mental health are much more commonly presenting in those deaths compared with heroin-related deaths. And also I took what Amanda presented and just pulled out the deaths that involve opioids that are used for pain, so fentanyl, morphine, oxycodone, tramadol, and codeine, so taking out methadone and buprenorphine. And actually, when we look at those deaths, half of them involve people who have documented chronic pain. So I think it does highlight that this is an important space to look at these harms. I think a common misunderstanding or assumption is that many of these deaths are made up of people who inject drugs. So again, when we look at this population, we see just under 1 in 4 of those people who use opioids for pain have a history of injecting drug use. So it does highlight that there are a range of different populations that we need to consider how we might reduce harms for those groups. So in terms of responding to those who have opioid-related risk, the point cohort has been, I think, a really fantastic study. Gab Campbell has kind of steered the ship, and the PI for that is Louisa Degenhardt. So this is a long-term study that's looked at trying to understand what happens over time for people who are prescribed opioids. So I've just pulled out a couple of things that we've learned from this study that really informs the work that I'm going to present today. So for example, we see when we look at addiction, which is a definition that's used by the American Pain Society and refers to when people are starting to have loss of control or compulsive use, we see 1 in 4 in this cohort of people, a community sample prescribed opioids for chronic pain. They weren't identified on the basis of having any kind of problems. 1 in 4 meet this criteria for addiction. It's around 1 in 5 if we look at the DSM-5 opioid use disorder. And we also see when we look at overdose risk among this cohort, again, 4 out of 5 have meaningful levels of opioid overdose risk for which the US CDC would recommend naloxone be provided. Yet when we ask them about their knowledge around sort of overdose signs and symptoms, very few are familiar with those signs. We also know from this cohort, when we've asked them about their concerns around their opioid use, around half are actually concerned about their opioid use, yet very few have ever received any kind of formal help. We've also seen from separate studies with health professionals that often this is an area where there's not a lot of confidence in how to bring up this discussion about whether or not there's risk and whether or not somebody might be experiencing opioid use disorder. So we identified this real kind of practice gap in terms of we know that there's a large population that might be at risk, that might not be aware of specific risk factors and how to respond, and that both the patients are unlikely to ask for help and health professionals might not be confident about how to bring it up. And the end result of this is that very few of those who might be at risk actually receive effective treatment or effective prevention approaches like naloxone. One of the things that there's been a lot of recent focus on is opioid dose and how that's associated with risk. And I think that perhaps we've gone too far in terms of focusing on opioid dose. We do know that dose is associated with risk, but actually when we start to look at what's associated with higher opioid dose, what we see is there's actually a really congregation of risk factors among those people on high doses. So those people on high doses also tend to have more severe and unmanaged pain. They also tend to have high levels of mental health conditions, be prescribed a higher number of other medicines, which increases the risk, and have other substance use disorders or use other substances. So often one of the approaches when we look at prescription monitoring, there's thresholds around dose, but actually trying to respond to the risk is much more complex than that. So the rationale that I guess sits behind this study is that we know many people are prescribed opioids for pain, and they are an important group in our mortality statistics. Not the only group, but an important group. We know this group often have multiple risk factors, And often they're unlikely to be aware of those overdose signs and symptoms to be able to put into place preventative strategies. And that's quite different to when we look at people who use opioids like heroin, who have quite high knowledge in this space. We also know that they're unlikely to seek help for opioid-related problems. And that's for a range of reasons, including being worried that their medicines are going to be taken away from them, which is a very valid and real concern for someone who relies on opioids for chronic pain. But in essence, this brings around a problem where we have a real role for outcome monitoring. More recently this year, there's been a number of changes implemented by the TGA and the PBS that have changed access to opioids. And one of those is a requirement to have a 12-monthly review to be able to continue on opioids from a second medical professional. And so again, there's been this increased focus on regularly reviewing outcomes. So again, this kind of supports the need for having approaches for routine opioid outcome monitoring. So that's the background behind why I started this work. And being a pharmacist, one of the spaces that there is a lot of opportunity, almost all opioids are supplied through community pharmacies, is to look at how pharmacists might be involved. But I would flag that the tools that were developed here were developed to be relevant across a range of other settings, in a range of primary care settings. And we do have current work going on in GP settings with these tools as well. So I guess it's good to think about some of the principles of when we do routine screening and monitoring. And broadly, there's a range of principles around doing this in pharmacies that should be met before you start suggesting that something should be routinely done. Things should have, the condition itself that you're monitoring for should have a significant burden of disease, and there should be interventions that work. Interventions should be evidence-based and appropriate for a pharmacy setting. And it's also important to do things like document and obtain consent to do screening, have appropriate follow-up and referral, and also that pharmacists are appropriate trained. So all of these things inform the work that I'm going to present today. There are also some broader principles of screening around that, that we should understand the condition and the target population. And I think in large part due to work with the point cohort and others, we do have a good understanding of the condition and the population. The condition should be important and treatment should be available. We do absolutely have very good treatments for opioid use disorder and to prevent opioid toxicity. And I think our mortality statistics make clear that the condition is important. I think where we fall down in terms of routine monitoring for problems is that when I started this project, we didn't really have fit for purpose screening procedures. There wasn't evidence that anything that we were going to do would be acceptable for patients, which is obviously key, and also acceptable for the healthcare professionals that might implement these things, nor evidence that these are cost-effective approaches. So I was lucky enough to be awarded a fellowship to be able to work in this space. And so as many people do when they start a new kind of body of work, we pulled together an advisory committee and we had a meeting to think about, well, how can we better identify these opioid-related problems? And this is really where the evolution of ROOM began. So our initial idea was that we would identify valid and reliable tools for opioid dependence, and there is a huge number of them out there. We'd do screening, maybe with an iPad, and we'd do, if someone screened positive, then we'd be able to refer them for help. This was our starting point. We had an advisory committee meeting, and there was really a couple of key barriers. The first of which was on when we reviewed these tools. So we brought in tools like the COM, the SDSS, the Orbit, and there is a number of tools, but many of these tools really have a lot of language which our advisory committee suggested the wording was really addiction focused, and that healthcare professionals wouldn't actually be comfortable asking questions that were worded like this, because it really sounded, we wanted something that you could ask or talk to anybody who was prescribed opioids, and the wording was considered to be a barrier if it really just focused on sort of drug problems. The other thing that was raised is that if we were just asking about any tool that was just focusing on problems with opioids and not considering broader aspects of clinical care, that people wouldn't necessarily want to ask those questions. In terms of a tablet, that was something that was felt to be good, but thinking about the really busy kind of workspace in community pharmacies, prompts and how people would remember to use it was a real challenge that was identified. So coming out of that meeting, I guess we had some really good direction in terms of identifying that we needed a broader screening approach for opioid outcomes, not just focusing on addiction-related problems, and we also needed to integrate this into pharmacy software. So I've sort of broken this down into a couple of challenges. And the first challenge of this work was really to get a fit for purpose opioid use disorder screen. So to develop a screening tool where the wording was appropriate for primary care settings for any patient that was prescribed opioids, where if somebody was answering these questions, they wouldn't feel like they were being accused of sort of using illicit drugs, or a lot of the wording in some of these tools really does center around illicit drug use, and these tools were developed for people who use illicit drugs. We actually had a previous tool that we developed for codeine dependence, over-the-counter codeine dependence, and the wording of that was felt to be really appropriate, but it wasn't something that would work with prescription opioids. So the first part of work that I did was actually to take existing data from the point cohort and try and look at questions in that cohort which were associated with dependence or opioid use disorder. We used the ICD-11 opioid use disorder, and this was based on responses to the city, so a diagnostic interview to determine if somebody had opioid dependence. And then using that, we're able to get a bunch of questions that seem to be not too addiction focused, but were good at predicting dependence, and then used both exploratory and confirmatory factor analysis to develop a 4-item scale. And I should give Associate Professor Raimondo Bruno a huge shout out for his assistance in this component of the work. So we developed an initial scale. It had a cutoff of 2 and was pretty good at identifying those that met opioid dependence. I would note that we've actually refined this tool even further, and what I'm going to present on the next slide is our refined wording. And if you want to get access to these tools, I've tried to put the QR code so anyone who uses that technology can access the full reference. But this is this 4-item tool with 4 questions where people can answer on a range of sort of responses about whether or not they've experienced these things. So whether or not they used opioids for other purposes, for example, to help sleep or with stress or worry. If the opioids were making them feel slowed down, sluggish or sedated, losing interest in usual activities, and worrying about opioid use. So this combination of questions was pretty good at predicting people who would meet criteria for opioid dependence as per ICD-11 criteria, using a long validated diagnostic interview. With each of these tools, and I'll give you the links to download these at the end, but with each of these tools we have a patient version, which is the green version, and a healthcare professional, which is the red version, which has the scoring, which I think could be a bit off-putting if you gave that to a patient, a tool with the scoring on it. So that's the reason that there's 2 versions. So here we have the summary of the tools, and these are references to the 2 papers and to acknowledge all of the people who worked on these papers with me. But essentially it comes down to these 4 criteria: overuse, being worried about your use, losing interest in usual activities, and feeling slowed down or sedated. And so for anyone, we've actually increased the cutoff for 3, and anyone that endorses 3 out of 4 of these items in the last 3 months, we recommend that that's a good point at which you might want to do a more detailed assessment to try and understand what's going on for that patient, and again, whether or not they feel like the benefits for them are outweighing any risks that they might experience with opioids. It is also worth, and this is something when I'm talking to healthcare professionals, mentioning that if someone even endorses one of those items, if somebody tells you that they're worried about their opioid use, that alone probably warrants a conversation to try and understand. And we do know some people are worried and may actually not use their opioids because of that worry. Other people might be worried because they're experiencing harm. So it is good to try and understand what's behind endorsing any one of those items. The next part of the tool, or the next challenge, was really to try and come up with to embed this sort of opioid use disorder tool into a broader tool. So we've got our validated opioid use disorder screening tool. Now we need to come up with something which is a bit more holistic, understanding that just asking about sort of addiction on its own it's not the only important outcome, and it also can be uncomfortable to focus on. So to do this, we're actually able to go back to a framework for a monitoring outcome with opioids, which is really well established. This was established more than 20 years ago now. Initially, it started being called the 4 A's of pain treatment. It then got expanded to 5 A's when affect was added, and now I've actually bumped it up to 6 A's because I also added in a screen around alcohol use, because there is a risk of toxicity when we combine opioids and alcohol. So this framework is the basis of the 12-item routine opioid outcome monitoring tool that we developed. And I guess the other things that we sort of know about monitoring with problems with opioids is there are some tools like the opioid risk tool that predict or try and predict risk, but these actually don't do very well in working out who might have problems later on. And so this approach from Pasic and Weinreb was really that we should monitor outcomes continually when opioids are supplied, as opposed to just trying to work out at the start who might have problems. So if we look at the room tool, and this is a summary, I've got the tool on the right-hand side of the slide that you can see. There is a PDF version that you can download. I'll give you the link if that's something you're interested in. But these are the domains that are in here, and many people might be familiar with the individual components of this outcome monitoring approach. So the first 3 questions is a 3-question, it's called the PEG. It looks at pain, enjoyment of life and general activity, really commonly used in primary care to monitor how people are going with analgesics and with their pain in general. Then we've got here this 4-item tool that you've just seen earlier to identify if people might be developing opioid use disorder or having sort of loss of control around their opioid use. And then we've got the PHQ2. This is just a very short 2-question screener to look at mood. It's been really well validated in primary care use. We also have some questions on adverse effects, which are really important for quality of life. It's always, I think often people find it a bit embarrassing, but constipation is a really common side effect with opioids. And so to ask about that. And we also have sedation here as a common side effect that can really impact on quality of life with opioids. And then we have a single question for screening for risky alcohol use. So we did actually do a validation study with this 12-item screen where we actually looked at longer validated tools and made sure that these short tools were performing well in people with chronic pain who are prescribed opioids for self-report. And so that work has just come out recently as well for anyone that's really interested in the detail around this tool. I also just wanted to flag, I'm not going to go a lot more into the clinical aspects, but if you are really into the clinical aspects, in a couple of weeks, I'll be doing a webinar where I really do a deep dive into each of the components, how they're scored, and also more importantly, how you'd respond if people screen positive on these. So I won't go into it now, but do feel free to check that out if you're kind of a clinically oriented person. So the final challenge now, we have both a validated brief screen for opioid dependence and this 12-item tool that we've validated, was to put it into practice. We know that it's not that hard to develop a screening tool, but getting people to use it and know and be comfortable using it is probably the biggest challenge. So we thought a lot about how we could make it easy for pharmacists to use, and we did a lot of work in consultation with pharmacists around the wording and the workflow. We did a similar consultation with people with lived experience around how to bring these things up. And we also looked a lot at implementation change and behaviour change literature and theories. I'm not going to go into very much detail rather than just to let you know that these are all things that we looked at, not just around the tool itself, but also thinking about the outer setting, policies, patient needs, the inner setting, what happens in a pharmacy that would make this work or not work, characteristics of pharmacists and their knowledge and beliefs, and also the process of how we put this into place. And also when we looked at behaviour change literature, we looked at the COM-B, which is this theory of that you need a combination of capability, motivation and opportunity to all be happening to be able to actually get behaviour change into doing a new thing. So in terms of the implementation study, we looked at capability, and we did have a training and education webinar for each of the pharmacists that were going to be doing screening. We had incentives for payments to pay people for their time, which is part of motivation. People will always need to choose between what they're going to do when you've got very busy environments. And we also had positive reinforcement for screening. And we're also doing something that pharmacists told us in our consultation was clinically important to them. So that also feeds into motivation. Then in terms of opportunity, we looked at things like having prompts in the software and other opportunities to facilitate this happening in practice. So we did this implementation study with these key features of having it software facilitated. We had parallel workflow, which I'll explain in a minute. So the screening happened at the same time that the pharmacist was preparing medicines. And we had a universal approach. So this is something we designed that would be for all people who are prescribed opioids. it isn't intended to target any particular patient group, and it's something that could be done by all pharmacists. So we wanted to have something that was scalable. So very briefly, what would happen is a patient would walk into a pharmacy with a script. The software would identify it was an eligible opioid script, and then the pharmacist would ask the patient, would you like to be in the study? They'd have a brief blurb. The patient themselves would do on an iPad, would complete these 12 screening questions. The pharmacist also had a short checklist which identified other risk factors. And then based on this, there would be patient and provider reports that gave the response. So all of the responses were scored by the software. And then depending on what risk factors were identified, the patient would also be offered naloxone. And if there was really significant risk, we trained pharmacists that they would, contact the prescriber immediately rather than just giving the patient a note for their prescriber. So we had these automatically produced reports, which I'm confident that you would not be able to read from where you are. But just in summary, they provided really brief information where pharmacists could reinforce key points. They also had links to websites. So for example, for patients, links to chronic pain management websites. They used population norms where it was appropriate. We tested the wording with experts and consumers to make sure it was acceptable. And there were links to further care. And there was also a summary report for the prescriber. So we had an implementation study that we conducted, as Professor Dark mentioned, 23 pharmacies across Victoria and New South Wales, with a real mix of metropolitan, regional and rural pharmacies. We had a baseline survey of pharmacists before they started their training. We gave them training and some on, I guess, the use of the screening tool and relevant patient counselling. And one thing I would make clear is that we really emphasised that this wasn't about identifying patients that shouldn't continue on opioids. It was about getting appropriate responses for patients that might be experiencing challenges, and also identifying where patients were doing well, which is also important because now we are required to have a review of where opioids should continue. Each pharmacy was able to do up to 20 screens. And then after they'd done that, we did follow-up surveys with pharmacists, and we also invited patients who completed the screen to give us an email where we could send them an evaluation survey. So in terms of the results, we had 23 pharmacies, 64 pharmacists that we recruited and trained on using the tool, and you can see their characteristics here. So as you can see, a good spread across New South Wales and Victoria. We had 70% were not in a capital city, so a nice spread. We do actually know that most prescription opioid related harms are disproportionately happening outside capital cities and in regional and rural areas, so that was important. So we had, of those, we had 20 pharmacies that actually successfully implemented this in practice. And then we had 4 pharmacies that did the full 20 screens, and we had an average of 8 screens per pharmacy. I thought that this maybe wasn't that impressive, but when I started looking at other implementation literature for things being implemented in community pharmacy, this is actually a very huge success. And normally these rates are actually, it's quite challenging to implement things in this very busy space of community pharmacy. So having 20 pharmacies do this at all and have most pharmacies doing a reasonable number was a relatively good outcome. And then we had 44 pharmacists that were able to follow up. There was a lot of staff turnover. It's not uncommon in community pharmacy, so we could not follow up everybody. We had 152 patients that completed the screening tool. 57 of those gave us an email, and of those who we were able to email, 32 completed an evaluation survey. And you can see their characteristics here. So we had a large proportion who were sort of older adults, and just over half were male. So in terms of the risk profile that we identified through this study, we actually found really significant levels of opioid-related risk among this kind of community pharmacy sample. So we had average pain scores of 6 out of 10. And we had, I think, just over a third were actually reporting that their pain was a 7 or more out of 10, which is indicating fairly severe pain despite receiving opioids. In terms of adverse effects, we saw that around 3 in 10 had constipation. Actually, 6 out of 10 reported that they were experiencing sedation, and we know that this impacts on quality of life, and it also impacts on people's ability to sort of get up and get out and about and do things. In terms of this addiction or opioid use disorder, we had 4 out of 10 people screen positive for endorsing those symptoms with opioid use disorder, so endorsing 3 out of 4 of those symptoms. So we had around 4 in 10 saying they were taking more than prescribed, and we had about 6 in 10 who were worried about their own opioid use. So actually quite levels of high concern among patients themselves. And you can see 1 in 5 met criteria for depression, and 4 in 10 were drinking at risky levels. When we look at this overall and include some of these pharmacist identified risk factors, such as being on a high opioid dose or also being prescribed benzodiazepines, we see actually 4 out of 5 had at least one sort of significant overdose risk factor. So it does seem when we think about things like naloxone that we probably should be thinking more along the lines of universal supply in this population. From the evaluation survey, we actually had quite good outcomes from those people. We had half of people who we surveyed said that they, as a result of doing this tool, had discussions around opioid-related risk and other factors with their pharmacist. And in addition to that, we had 1 in 4 actually attended a referral appointment to be able to address these issues. So in terms of that idea that, we knew prior to doing this that, very few people were actually asking for help or bringing up problems, that we did feel that this indicated we were successfully getting those conversations happening for patients. It was a little disappointing that only 1 out of the 32 actually received naloxone as a result of this study, although I would know that this happened before naloxone, the Commonwealth pilot, so there would be a significant cost to buy naloxone, and that's probably a significant barrier for many patients. We also found, in terms of acceptability, and I think this is really important, the patients rated in terms of ease of completion 9 out of 10, and they also said 9 out of 10 for the relevance of the information that they received. So this was something that was acceptable to patients. And in our validation study as well, we had very similar scores. So a median 10 out of 10 score for how acceptable the questions were. So at least that consultation with people with lived experience really did seem to inform that we had this right. In terms of pharmacist outcomes, this was a mixed result. We found significant increases in pharmacist confidence to be able to respond to opioid-related problems as a result of being in the study. So when we compared to their baseline scores, we saw significant increases in 4 out of the 5 domains. Seems like pharmacists were already quite confident talking about constipation, but maybe less confident talking about some of these mental health, opioid use disorder, unmanaged pain, substance use issues. I guess the downside is that at follow-up, our scores of how confident pharmacists were to respond to these issues was still only moderate. So it seemed like we still have a way to go to really lift that level of confidence to deal with this fairly complicated clinical area. And just finally, in terms of looking at which pharmacists were more likely to be implementing room and doing this screening with patients, we found that those pharmacists who had been practicing for longer, those pharmacists that had less knowledge about naloxone, and those pharmacists that were less confident in identifying and responding to unmanaged pain were less likely to do this screening. And we've seen this with things like alcohol use disorder as well. If you don't know what to do if a patient screens positive, you're much less likely to screen a patient to find out if they've got a problem because you feel not confident in that area. Some of the things that weren't associated with doing the screening were things like their perceptions around the importance of evidence-based practice or harm reduction. So it wasn't really a sort of a value judgment around whether or not the screening should happen, but really around these issues of sort of confidence and knowledge. So I guess just in terms of wrapping it up, through this program of work, we were able to develop what was a brief and acceptable outcome monitoring tool. We developed it and we validated it, and it seems like it is sort of feasible to use this in a pharmacy setting. It's acceptable to patients, but there are some challenges in terms of implementation. It was variable. Some pharmacies were really able to do it quite easily. Others really had a lot more barriers in terms of getting it going. And it does flag that we probably need to look at what implementation strategies are most effective to be able to support this happening in community pharmacies. So that's probably the next big piece of work. We still have a challenge in this clinical area. The moderate levels of confidence at follow-up suggest that we need to go further in terms of supporting pharmacists in this area of practice. We did find that most patients had really significant levels of risk, and I think we need to think about how we're going to meet the needs of this patient group. And think about, where and how a response is best delivered for this patient group. We know a lot of recommendations are often if we're identifying opioid use disorder, maybe to refer people to drug and alcohol services, but that's not something that's necessarily going to be particularly appealing to someone that has chronic pain and is prescribed opioids. So we really need to think about where we're going to respond when issues are emerging. And I think a really critical issue is thinking about how some of these new restrictions on opioid supply are going to impact on this patient group, and how some of this outcome monitoring might help work out with the patient at the centre of that decision making, whether or not benefits are still there in terms of opioid use, or whether or not other strategies might be more appropriate. And I guess in terms of a new piece of work that I'm starting, we are starting to look very closely at primary care data sets to try and look at the impact of these restrictions on opioid prescribing to understand better what happens for patients. Just to finish with an acknowledgement slide, I do want to acknowledge many people. You've seen the people who are involved in the publications that I've presented along the way, but behind the scenes we have an advisory board that gave us very sage advice early on in the study. A lot of pharmacists and participants and people with lived experience who we consulted in the development of the study and asked a lot of questions around wording and workflow and what would be acceptable. Obviously the collaborators and co-authors who are all listed throughout the presentation. And there was also a range of funding that that supported this work, so the NHMRC Fellowship, but also just the support to develop the tools themselves initially came from the Central and Eastern Sydney Primary Health Network, so very grateful for that, and also Western Sydney Primary Health Network supported us in doing the study along with a Mind Gardens seed funding grant. For anyone that wants to download those tools, they're at the website at the bottom of the page as well, or if you use the QR code, I think you just put your camera on and hover over that part of the QR code. They're all free to download from that website there with no restrictions. That is all from me, so I think I'm going to stop sharing now.
Great, thank you, Susie. And Gab, can we have you please on camera and unmuted, por favor? Oh, there she is. That's Dr. Gabrielle Campbell from speaking to us from the beautiful Sunshine Coast in Queensland. Great talk, Susie. I might just start with a question to you, and then I'll move over to Gab for her view. I think we discussed this at other times, but this is all about really prescribing and harm in the long run to the individual. And you alluded to, like, the United States has what we think is a gross overprescribing with huge death rate. Perhaps Africa has underprescribing. I suppose the question I've got is how does one as a society determine what's an appropriate level or chronicity of opioid prescribing?
Yeah, I think that's a really good question, because we do hear that, I mean, obviously the levels of prescribing in North America are far greater than any other country where there's comparable levels of pain. So yeah, how much is the right amount? I think at the moment, what's probably more important is to think about what's the right level of opioid prescribing for an individual person in front of you. And then we also need to recognise that we now know that maybe the long-term effects of opioids, they're not as efficacious for chronic pain as we might have thought 20 years ago. But when we have patients who've been on these medicines for many, many years, often 10 years or more, if those patients are still doing well, and if there is a low level of risk, if the opioids that they're taking allow them to function, allow them to have quality time with grandkids or get on with work, then that probably is the right amount of opioids for them, even if the number might be higher than a current threshold. So I do think we really need to take very individualised kind of considerations when we're thinking about what's the right amount of opioids, and also think about the history. So if someone's got tolerance, they've been on opioids for a long time, it might not be an opioid dose that we would start somebody on today, but it doesn't mean that those patients should be cut off their opioids or being forced to taper down because of an arbitrary threshold. It does need to be much more tailored, and it does absolutely need to be in consultation with the patient. So yeah, we hear really concerning things about forced opioid taper, and while people might have their best intentions on like reducing opioid to reduce risk, the outcomes where people are forced off opioids are generally not good.
Yeah, yeah. Gab, I suppose just relating to that, because you've got long experience with the POINT study, which was about, for those who don't know, is basically is a longitudinal study on people with chronic pain and looking at opioids and other drugs involved. I suppose from that perspective, how do you see what you fit in with what Susie has been saying and is achieving, and your perspective from having worked with the long-term outcomes of people with chronic pain?
Yeah, I commend Susie and her work doing all this stuff to try and sort of help these people sort of with chronic pain and opioid use disorder. And as sort of Susie's gone over previously, that there's different terminologies used for addiction and use disorder amongst the groups. And I think a lot of the people are getting their medications from GPs. Not many people are going to pain management courses or pain specialists to get their medications. The commonly cited statistic is that the GPs have 7 minutes with each patient, and they don't really have a lot of time to be able to engage with the people and track what's going on with them each time they're prescribing them their monthly dose of opioids. So trying to broaden out to sort of pharmacists or trying to get other people engaged to sort of, you know, be on top of the problem and sort of help these people to sort of see in case they do have concerns. And as Susie said, like about 2/3 of them do sort of note themselves that they are worried about their own use. So broadening out your sort of primary healthcare network to us getting pharmacists involved, I think is a fantastic idea.
Yeah. Now we've got a question from an Mr. or Ms. A attendee, which is, I think, relates to something. I think it's a very good question because it relates, and I'll get both your views on this, but I'll start with you, Susie. As you know, I've had a long interest in naloxone and prescribing, giving it out in the community, but it's been very much focused, as you know, over the years on injecting drug use. Now, the question from the floor is, do you have thoughts about whether patients, so the chronic pain patients who may have no history of injecting drug use, would be comfortable to carry naloxone? The question is, they're wondering if it's associated with illicit drug use and it might carry a stigma. Do you have any views on that?
Yeah, look, that's a really excellent question. And I had the same question. So we actually asked a group of patients in the point cohort, we explained to them what naloxone was, why they might have it in their home, and asked them what they thought about it. And we actually found that the overwhelming majority thought that naloxone, chronic pain patients prescribed opioids thought that naloxone was a good or a very good idea. And actually, again, the overwhelming majority would appreciate or in fact expect that a healthcare professional would offer it to them. So we do say that's acceptable to patients, but it all depends on how it's brought up. And I think that one thing that we've learned from some very recent research that was just completed in the last couple of months, we actually looked to develop resources around naloxone and overdose prevention with people who are prescribed opioids for chronic pain and pharmacists. And we used sort of a co-design approach to come up with both information sheets for pharmacists, information sheets for patients, and short animations that had information that was really tailored to people who are prescribed opioids, because there are fantastic resources out there for naloxone. We've seen sort of peer groups do incredible work around overdose prevention, but most of those resources really had language and information that just wasn't relevant. So tips like don't use alone, halve your hit. That doesn't make any sense for someone who's prescribed opioids. So we came up with, I guess, messaging and resources around how to have those conversations in a pharmacy setting and for people who are prescribed opioids for pain. So I think when it's approached with the right language, that works. We did learn through that work that the term overdose is particularly problematic. So what people with chronic pain often perceive, if you ask them overdose, what do you think an overdose is? Some of them thought it meant addiction. Some of them thought it meant suicide. Some of them then thought it meant taking all of your medicines at much. Very few of them actually described what we would define as an overdose. So if we use the term overdose, we're probably going to lose people. We probably are going to have some of that baggage and stigma or even just confusion, thinking, oh, this isn't relevant for me. I don't use illicit drugs. So language is important across the board. We need to reduce stigma, but particularly if we're trying to have clear messages around reducing risk with overdose, with opioids, the term overdose doesn't seem very salient for people who are prescribed opioids. They don't necessarily interpret it the way we mean it.
Yeah. Gab, do you have any views on naloxone or the fact
No,
that the population you'll be looking at is quite a different population than illicit drug users?
and I think, yeah, I think that's the same with people who develop opioid use disorder, and about there's stigma associated with methadone and buprenorphine as well. And so we need to try and reduce the stigma that's associated where people's used to people who use heroin having naloxone or going into methadone or buprenorphine. And so actually we need to reduce the stigma associated with it so the people with chronic pain can go to it. Whether that's new treatments, I don't know, Susie's probably more knowledgeable in that area, but the nasal naloxone, using bupe depot instead of sort of the going to the clinic every day. So yeah, there's just a number of things.
I think nasal is a potential game changer for a population like Susie's describing. We've got a question here from Simon Brisbane. It's very inspiring work, Susie. I've been looking for a way to reach at-risk folks through pharmacies in regional areas, part of an OD prevention program. Simon's saying finds it generally difficult to get buy-in from pharmacists. Do you have any suggestions about how to get buy-in from farmers, how to get pharmacists involved?
In terms of talking about some of these risks,
yes,
I think some of it is actually unpacking some of the overdose statistics. So I think there are actually misconceptions around who's experiencing harm, and sometimes it isn't actually commonly understood that, you know, yes, there are people who inject drugs that we find in our opioid mortality statistics, and they absolutely need appropriate interventions. But we also see people who are using opioids therapeutically in those mortality statistics. And so pharmacists do have a role to play. They are the people who are providing those opioids. And often, I mean, people trust pharmacists. People have very good relationships with their pharmacists. They see them really regularly. So I guess trying to harness that you know, really good relationship that happens already. There is a lot of work going on with the Pharmaceutical Society of Australia and others to really bolster confidence in this area. I think there is a real need for training needs in general. But I think just understanding that this is something, I mean, the harms that we see with opioids, they don't reflect on the people who are taking the opioids, they reflect on the medications themselves. Yeah. The medications themselves do have side effects, which include dependence. And so often I think we frame it as a problem with the patient, and I think we frame it as, you know, a challenge with the medication. These aren't perfect medications. It's not about blaming pharmacists. It's not about blaming doctors. Yeah. It's not about blaming patients, but just really trying to understand that, you know, they're not perfect medicines, and we all need to work together in that response.
Yeah. Now I've got a question. I'm going to throw to Gab because it's an area of expertise and she's published internationally on this. It's about alternatives to opioids, and it suggests that this is the chronic pain and medicinal cannabis. And it's exciting, the study that some US states have had lower opioid use and death rates, which from memory, my memory was hotly contested, and the study was had a lot of confounds. But I suppose you've done work on chronic pain and cannabis, your comprehensive review. Do you have any general views on that as an alternative?
So probably the study that's being cited, when they've recently redone that study and looked at a longer term, it's actually flipped. And this author sort of saying we can't actually say that, you know, cannabis legislation for medicinal purposes increased opioid overdose deaths. So it's just got something to do with, you know, it's a correlational study. We don't really know what's going on. In terms of chronic pain and medicinal cannabis, the evidence is still a bit controversial, and the reason for that is there hasn't been those really good long-term studies looking at the effectiveness of it. There haven't been those really high-quality studies. It's not to say that it's not going to be useful for people. We just don't know it yet. And, you know, it is the lesser of two evils when you're looking at opioid overdose, and sort of you're not going to overdose on cannabis. But I guess it's also making clear people's expectations around cannabis use and what it will do for chronic pain, because the evidence is not that convincing that just yet, but that's not to say that it's not going to be. We just need those better studies to come along. And that's because also it's still illegal federally in the US. So those big US studies can't be done just yet.
Yeah. Susie, did you have anything to add to that, or?
Yeah, I mean, I guess to add, I mean, Gab and I shared the joy of doing these very large systematic reviews.
Yes.
I mean, there is evidence that cannabis and cannabinoids will reduce chronic pain, but I think what's important in terms of understanding the evidence is that the magnitude of the effect is quite small. You need to treat, I think, 22 to 24 people for one person to have a good response. So it's not like the evidence doesn't say it works, but it seems that the number of people that you might expect to have a benefit and the size of that benefit is probably not huge. And so I think sometimes there's been like a lot of promise. People really feel like this is going to be the one thing that's going to make a difference. But the evidence shows that it doesn't work for everyone. And those people it does work for, it's probably a relatively sort of modest effect for pain. But again, there's probably still a lot of work to be done to work out, you know, are there particular patients or particular conditions that might, you know, where you might see that better effect?
Yeah.
And I guess I would agree with what Gab said around the kind of ecological evidence. The fact that, yeah, when they reanalyze the data a few years later, that those beneficial effects at a state level were no longer seen. And the real challenge with, I think, some of those studies is we don't actually know. It was basically looking at the effect of a law to make cannabis available. We don't actually know if those people who did or didn't die had access to the opioids or sort of cannabis, or if that changed as a result. It's really just looking at that very...
These were, as Gab said, it's correlation. These weren't clinical studies.
Right. But they did obviously get a lot of attention, those studies, and drove a lot of, I guess, debate.
Yeah, absolutely. Paul Grinzi has a question for you, Susie, and you alluded to overdose as a term that's not salient to people without a history of illicit drug use at any rate. Were there any other words there or terminologies that you found that didn't gel or imply was stigmatizing or cause concern, or was it only overdose? Or
look, overdose, I think overdose, the term is, I think, a barrier, because not only there is just such incredible stigma around substance use, but also people don't necessarily think it means what we are saying when we say overdose. I think in terms of the tool and in terms of the acceptability of the wording, I guess we'd already gone through very carefully and tried to choose, when we're looking at questions around opioid disorder, things that were relevant to people who were prescribed opioids for pain. So we weren't asking people about kind of, in a sort of a drug use framing, was really around asking about their medication use. But some of the other information that we had when we were developing, not just the tool, but how to introduce the questions, like the wording that goes in between the questions, like explaining why we might want to ask about alcohol use, for example. You know, why is my pharmacist asking about alcohol?
It's obvious to us, but it's
not. So just being able to have some of those things to explain, and also, I guess, in terms of the normative data to, I guess, in the responses, and when we're talking to people about these things, let them know actually you're not alone. Many people actually are worried about their opioid use, and letting people know what they can do. I guess the final kind of thing that we learned from the most recent study was that patients who are prescribed opioids are already acutely aware around the restrictions, around the concerns, and around the fact that they might have trouble accessing their opioids in the future. And so empowering patients, having that trust, making sure that patients feel like that control isn't going to be taken away from them, and having them being a partner in all of that stuff is really important. So we heard very clearly that we know that there's a problem here, but we want to know what we can do and what's positive. We don't want to be told to be afraid of our opioids. So I guess that was the other approach.
Yeah. I suppose part of the thing that and I'm going to get Gab's comment here, part of what you focused on is these are people in pain. Let's not forget that. And you were talking about cutting people. Now, the reason I mentioned Gabby is because with the point study, one of the major findings that came out of Gab's work, which I think was groundbreaking, was the strong link between chronic pain and suicidality, and that was actually independent of depression, Gab. That's correct. So it's a complex question. I mean, do you have any views on, Gab, on, you know, pain, suicide, and the balance of opioid use?
I think it could go.
It's an easy question.
I think it could go both ways. I think there's I think one of the easiest ways to look at suicide prevention is means restrictions, but taking away people's opioids because there's a relationship between people taking opioids is not going to work, because then there's also the concern that taking people off opioids is going to lead to suicide amongst these people, because the fact of the matter is these people have to live with pain for a long period of time. There's no other solutions. We can't turn around and say, here's the magic pill, come off your opioids, you're not going to feel pain. They're going to feel pain no matter what. So it's working out for each individual how to manage their own pain, and whether that be someone can go to physical therapy and that helps them, whether someone else prefers medication. It's trying to work out sort of that approach for each individual and what's going to work for them. But it's also, I think, when you do get these medicines coming out saying, this is groundbreaking, this is, they just had Lyrica coming out, and then it does nothing. It doesn't do much for their pain. That can also lead people to those suicide thoughts and behaviours, for this realisation that they're going to be like this forever. So it's about sort of changing that mind frame that they have about dealing and living with their pain.
Yeah.
As well, with
comments on that?
I was just going to say, I think one of the things that there's a lot of kind of talk about at the moment is opioid tapering, which I think is it's a really important and interesting idea when we think about opioids. We do actually know that for many people on long-term opioids, that it can make them actually increase their sensitivity to pain, and that reducing that opioid dose down can have positive effects. But it's the way that it's approached. So I think if it's approached in terms of asking a patient, would you like to try this? Do you think, we know that this is something that might help with your pain. Would you like to try coming down on the dose and seeing if you do experience benefits? That's quite different to being told or seeing a policy that says kind of a blanket approach that maybe it will be harder to get opioids. And so they're quite, it's the same outcome overall, but it's just the way that it's approached can be quite different. And I think even sometimes, when we use this tool and we monitor, we ask people regularly, how's your pain out of 10? How much are you able to do despite the pain? How much is pain affecting your life? If someone's had a big dose increase and you keep asking those questions, and you can actually show them, well, we asked you before we put the dose up how you're going, and actually it seems like putting the dose up hasn't really helped you achieve your goals, then that's an easy way to reflect on whether or not the opioids are helping by having these objective measures and validated tools to look at outcomes and patients' goals.
Yeah. I'll wrap up now. I'll just say Matt Stevens, who asked some of the questions, said, thank you for a fantastic talk and discussion. And a comment here was quite right from one of the attendees. And I don't think we were suggesting that it was an assaulting, but depression is only one risk factor for suicide, and that's true. There are other constellation of things that are going to go along with chronic pain, burden on others, isolation, loss of role. That's a very important point and well made, which I suppose gets back to what you're presenting is a very complex picture. Both of you, it's a complex picture. But I think it's a great intervention, Susie, and I'd like to thank you for all your hard work, and Gab, and for the presentation. The pharmacists of Mars are here, up on their feet and cheering as one, you may be rest assured. And Gab, thank you for your input. It's been a great panel discussion to have, and a real pleasure to have two experts of such standing to present today. And thank you all out there for your attendance at this webinar. It's been a real pleasure to present it, and I wish you all a wonderful afternoon and a fabulous evening. Thank you. See you later, everybody.
Thanks, Shane. Thanks, Susie.
Thanks for having me.